Yes, so anti-BCMA CAR T revolutionized the treatment for relapsed refractory myeloma, and it's already an approved therapy, but still there are gaps in the accessibility of this therapy, the cost of this therapy, and this is why academic CAR T are very important to try to make this therapy more accessible. So HBI-0101 is a novel second-generation optimized anti-BCMA CAR T that was developed in Hadassah Medical Center, Jerusalem, Israel. And we reported in the past in previous meetings about the efficacy and safety of this CAR in a phase 1A and 1B study. And this is the summary of this phase 1A/B study, which is a relatively large phase 1 study with 130 myeloma patients. AL amyloidosis patients were also treated in this study, and we were the first to test anti-BCMA CAR T in patients with AL amyloidosis. But here in this presentation, we focus on myeloma. We enrolled patients after at least 3 prior lines of therapy, including a proteasome inhibitor, immune modulator, and an anti-CD38 antibody. And other inclusion criteria were relatively very permissive in terms of thresholds of platelets. That was 30,000, creatinine clearance of 20 ml per minute, echo performance status of 2. We started with 150 million CAR T cells in 6 patients, and then 450 in 7 patients. But all subsequent 117 patients were treated in the target dose of 800 million cells. It was the dose that was found to be the recommended dose for the 1B. And this presentation summarized the results in these 117 patients. Almost all or many of them were triple refractory patients, median 4 prior lines of therapy. About a fifth were had true extramedullary disease, and 35% had a high-risk FISH. And in terms of manufacturing, it was very good. The manufacturing success rate was actually 100%, with 92% receiving the target dose plus minus 20%. Regarding toxicity, like all other anti-BCMA CAR T studies, CRS was very common, but actually we saw only 1 case, so less than 1% of grade 4 CRS, and we didn't have any grade 5 CRS. And we only had 5 cases of ICANS, so 4.3%. We had 3 cases of death that were possibly or partially attributed to the CAR T. And the overall response rate was 93%, with complete responses of 71%, MRD negativity of 77%, so very active CAR T. And with a median follow-up of about 2 years, the median PFS is 14.6 months. So overall, it's an active CAR T that I think is important in the field because of the gaps in the accessibility to CAR T worldwide. And we also saw, like many other CAR T studies, that extramedullary disease and prior anti-BCMA therapy were predictors for worse progression-free survival as expected. But as I said, we treated a harder to treat population, and when we checked that, the incompatibility with the inclusion criteria of at least one of the registrational trial with the commercial CAR T also was associated with worse PFS. So maybe in a population that is more similar to the other CAR T studies, the results would have been even better. And this study is I think more reflecting the real world population.